This committee to order. We have a quorum and appreciate everybody's patience. This time of year, people are presenting at other committees, including two of our members who are presenting at the House Health Committee, one of their committees. And so they'll join us when they can. But we have our quorum, and we're going to go a little bit out of order with Chairman Stevens, since that's a very quick bill. If you don't mind, anywhere you would like, right there will be perfectly fine. And so we're doing, let's look at the very back of your folder. That is the annual Controlled Substances Schedule Update, House Bill 473. All right, the floor is yours, Chairman.
Thank you, Mr. Chairman. Members of committee, this is our annual update for controlled substances and for regular drugs that are just our prescription items. Very quickly, the first one that you'll see is an opioid designer drug. The second one's a synthetic mushroom-type drug. The third one is ethylphenidate. That might sound familiar to methylphenidate, which is Ritalin. Ethyl is illegal. Ritalin is a class 2. And the fourth one there is a sports doping drug. The rest of these are just normal prescription drugs. And, Mr. Chairman, that is the bill.
Any questions from the committee? Let's see. Yes, sir. Mr. Rules, Chairman, you're in on mic number 2.
Yes, sir. Could Chairman Stevens go line by line and tell us what each one of these is?
Glad to.
I'm just kidding. You don't need to do that.
I was expecting to do that.
All righty, got a move, do pass. Second. Discussion.
I'll second and start this
Okay.
one. Got me. Can you just repeat what you said one more time?
Sure. These first ones under section 1, 2, 3, and 4 are all Control 1 Class 1 drugs. These are drugs that are highly addictive and have no medical use. That would be things like heroin and so on and so forth. And periodically, you'll have some of these folks in their own house that will chemically rearrange these drugs that may have even been a legal drug. For example, this one, Section 3, ethylphenidate, has no medical use, but methylphenidate is used for kids as a stimulant for ADD. So whenever you chemically change these drugs to make them addictive but not have a medical use, they're in this Class 1 narcotic. That way they know how to go prosecute somebody if they've created a bad drug.
Thank you.
Any other questions? All right, so we're in the posture of we have a do pass, seconded. No further discussion. All those in favor say aye. Aye. All those opposed, like signs, passes unanimously. Thank you.
Thank you, Mr. Chairman, members of committee.
Let me do one thing. You have somebody who's carrying that?
I think traditionally the chairman.
Be happy to, yeah.
Thank you,
Okay.
Mr. Chairman.
Thank you.
Chairman, I just for the record want to tell you that I had fun working with this gentleman about 14 years ago.
On the other
I
side.
can't even believe it.
All righty.
On the other side.
We-
I had black hair.
Thank you.
I had hair at that time. Take care.
All right, Representative Chair Lady Cooper, we're at House Bill 89 and LC 570207S.
That's right.
And it has not been changed since it's been voted on, correct?
No, sir.
Okay, all right. And do we have sign-up sheets? Okay, so Chair Lady, why don't you go ahead and present the bill? We'll look at the sign-up sheets and sort of go from there.
Okay.
Thank you.
Thank you, Mr. Chairman. What House Bill 89 does is very important to our state. It sets up a Regional Perinatal Center Advisory Committee. We have 6 regional perinatal centers across our state, and there is a colored form in your packets that show you where those centers are and the regions they cover. There is maybe that they might need one more, and that's up in the Atlanta region only because it covers such a large number of counties. But right now we have 6. And this advisory committee is needed to make sure that they're basically all working off the same page and are, telling people the same thing and working toward a common goal. And that would be because we don't have enough OBGYNs across our state. We don't have enough pediatricians that specialize in treating newborns, and especially if they were preemies. And so each of the centers, if someone is having trouble, they're sort of like this, they're the hub. And then people working out in the area are the Stokes of a wheel. And so if they have questions or need help, they could refer to one of these centers. And each of the centers will have like a pediatric cardiologist and a newborn specialist or a preemie specialist, so that they would be able to get to those people to advise people out in our more rural areas. So it sets up a committee to set up the parameters and to work with these regional centers that we already have. There's also the latest on our maternal mortality report in your folder. It is this one. And it was from 20 to 22. They're always behind, not as far as they have been in the past, so they are making strides. And perhaps the biggest area of increase and reasons for maternal mortality is in the mental health field. And one of the problems that we have had are the people that do the nurse extractors that go out to get the information when there's a death, have trouble getting psychiatric records from doctors and from hospitals. Hospitals and doctors never have made it easy to get information because of HIPAA and because they don't want any of that information out. But when it comes to psychiatric information and what kind of problems like addiction or so forth, they have been more reluctant to offer that up. And so this sets up the fact that we can have it, or that the nurses call nurse extractors that then report to the maternal mortality committee can get that information so they can process the whole situation correctly on each mother that has passed away. The other thing, it sets out who is going to do the autopsies, because the people they had doing the autopsy didn't want to do the autopsies, so it sets out where the autopsies of a mother that has lost her life during delivery or after would be autopsy, and that's what it does. And Megan with the department is here. If anybody has a question, I can answer.
Yes, I have a question. Number 3, Senator Halpern.
Good afternoon, thank you. I do have a question. I'm going to lead it in, though, with a statement. This past summer, as you all may know, the regional perinatal centers got together on a meeting that was initiated through our Department of Health and Dr. Toomey. And it also included DBHDD. I mean, I think what was important about that meeting is that was the first time that we had both of those departments and the perinatal centers together. So I was part of that meeting as well, and appreciate and think that some of it, well, let me ask you a question. Is this kind of one of the outputs of that meeting and some of the decisions that were made over the course of that weekend in terms of how we can have each of those centers better work in concert with each other? That's one first question.
Just to be honest, I don't know that in detail, but from talking to people, I think that is the overall view of what it was supposed to do.
Ms. Andrews, you mind
Saying
grabbing a mic there? W3 would be good, and just give us some background on this, please.
Hey, everyone. For those of you that don't know me, I'm Megan Andrews. I'm the Assistant Commissioner for Policy at DPH. Thanks for having me here. Yes, this is an output from that meeting where we were working with the regional perinatal centers to develop priorities for this session. So this is one of them, along with some budget items that the governor funded, and you'll be seeing here in the next couple of days coming over to the Senate.
Can I just ask a follow-up question?
Sure.
So, I want to better understand, though, how the relationship of this advisory committee, what it will be with the Maternal Mortality Review Committee. And I'm less clear about that, and I
Yeah.
want to assure that those two things are still distinct.
Yes. Yes, certainly. So the Maternal Mortality Review Committee, MMRC for short, they review case-by-case maternal deaths, in-depth medical records, family interviews, all of that. That work will continue. This group will be looking at the hospital-based system of care that we have and working collaboratively to decide, do we need to add another regional perinatal center? If we do, where should it be? This map hasn't changed in over 30 years. And obviously the population in Georgia has changed in that time. So we expect a need to add another center, but want to work collaboratively with the hospitals to come up with what that recommendation should be. So that's what this group would be doing.
Thank you.
Yes.
So department fully supports, and would this be considered a department bill?
This
or-
is a department bill, yes.
Gotcha, okay. Central Rock is on number 8.
Thank you, Mr. Chair. Good to have you all with us, and thanks for bringing the bill. I had an opportunity to meet a physician coming from Harvard that's at Emory now, and he's developed a screening for finding expectant women that are prime for preeclampsia, which and I don't know where that fits in these leading causes of pregnancy. What does that come under? Is that cardiovascular or?
Be under cardiovascular.
I'm sorry?
Cardiovascular.
That would be cardiovascular.
Yeah.
Because that is a new frontier in a sense. I mean, first time I learned about it was happening to be at dinner with this doctor who's been here for 3 years from Harvard. It's a breakthrough, and you know, another piece to add to our what we bring to the table to address this alarming number of the maternal mortality statistics for the state, and that's not mental health conditions. Where's the department on that?
Well,
The behavioral health department?
On the preeclampsia testing?
No, I'm sorry, I jumped.
Okay.
I jumped on because you referenced, Madam Chair, that getting mental health
Yes.
assessments were difficult, challenging, problematic. And where's you can't speak for that department, I'm sure, but is there can you shine any light on how to go about fixing that?
So,
okay, go ahead.
are you okay?
Well,
Mental health,
I
yeah.
do know, I don't know whether we would have to have legislation to use that kind of screening.
I mean, I think she switched gears from
talking
preeclampsia
about
to
Oh.
mental health.
Yeah.
Mental
Megan?
health, yeah.
Oh,
thank
you said, okay.
Uh-huh.
So the challenge has been there's stricter confidentiality provisions around access to mental health records
That's fine.
that mental health providers have cited in their reasoning for not sharing that information with the review committee. So they've been having to, in some cases they're able to access the records and some they're not. This is to make clear that this committee should have access to those records to review and then make recommendations for ways that the state can improve in addressing those
So
issues.
that's addressed in the bill.
That is, yes.
Thank you
Certainly, if
very
we're
much.
doing autopsies, then I think that's
Yes.
sharing those records, I think, is self-explanatory. I got it. Anything else? Discussion from the group?
Matt,
Senator Mangum, you're on number 5.
Yeah. To the Madam Distinguished Representative, and maybe Ms. Andrews, I noticed on your list, the second, you say pregnancy-related mortality, and then you say preventable. There's not a lot about the preventables.
So if you look in your, once you get one of those, go through it, and we can follow up later on that one. Any further discussion? No further discussion. I'm happy to hear to entertain a motion. All right, motion do pass, Senator Mangum, Chairman Brass. Any other discussion? All those in favor say aye. All those opposed, like sign. Passes unanimously. Thank you.
Mr. Chairman, may I say something?
Certainly.
Just so, I will tell the committee that there is a test that is being used in England. This is on preeclampsia that gives doctors an indication of who might be likely to have a problem with preeclampsia, which is one of the major causes of death.
We
And I
got it. All
know
right.
that we have tried to get a bill okaying that through over in the House a couple of times, and we will
That's
continue
a,
to work on.
that's a discussion for another date. Preeclampsia's been going on for forever, and you're right. There are certainly good breakthroughs. There's been a breakthrough numerous times, so we appreciate that. So, let's see. Carrying that bill,
Senator Hatchett is carrying.
just as he arrives.
Yes.
That's,
Just in
that's
time.
what you get for being late arriving. You get to carry the bill. Yes, sir. Governor's bill. That's right,
And if
OBGYN.
anyone wants, yes, these are hot off the press this week,
Yes.
the latest report.
All righty. It sort of gives explanation. All righty. Senator Hatchett's got it. Okay, so then lastly, but not least by any means, Representative Seaball and gestational diabetes management. And we have a substitute that I just want to explain, and this is another discussion with DCH, and I'm sure they have someone here. I know they have someone here, but I want to. We have a couple of folks who are in Washington, D.C. that we've been communicating with, and the change that we have as a substitute struck through line 21. And this would allow an automated prior approval process, very provider-friendly, and that would make it easier to get the continuous glucose monitor. Representative Seaball was agreeable to that. I was obviously agreeable to it too. We wouldn't be seeing it, and then and this was recommended by DCH. So not a department bill, but a very important bill. And Representative Seaball, I don't want to steal your thunder, but I just wanted to just sort of get some clarification, because late arriving substitutes, we're always highly suspicious when it comes to what was voted on, what's changed. So that's where we are. I just want to make sure that the committee is all on the same page. Thank you. Good question.
It's, if I may, it's 520828S.
Let's make sure we're all clear. LC 520828, yes. Excuse.
All right. Thank you, Mr. Chairman. Members of the committee, today I'm presenting House Bill 352. It's a simple but significant amendment to a bill that we all unanimously passed last year and was signed into law by Governor Kemp. The amendment ensures that Medicaid will cover continuous glucose monitors for pregnant women diagnosed with diabetes, and we've added the word gestational diabetes. Just to be clear, as you all know, words matter, so we wanted to come back and add gestational diabetes to that, if their physician prescribes it. And back on line 12, we simply changed the date to reflect 2025. So why is this necessary? Gestational diabetes is not just a temporary condition. It presents serious health risks for both mothers and babies. And the efficient management of blood sugar levels with the help of a CGM is critical to preventing complications such as preterm birth, high birth weight, and the future development of type 2 diabetes. So a CGM provides real-time data to help expecting mothers maintain stable glucose levels and reduce the risk of needing emergency interventions and costly complications. So the language of this amendment is clear and consistent with the original law. It simply ensures that Medicaid covers the essential tool as prescribed by a doctor for a woman with gestational diabetes, thus removing a potential unintended gap in coverage. It upholds the intent of our original actions last year, which was a commitment to protecting maternal and infant health in Georgia. So I urge your favorable consideration. And just quickly on line 21, 21, originally we had struck the words "at least one daily administration of insulin." We just simply added that back, and we added on letter B that they have gestational diabetes. And that's the change, and I'm happy to answer any questions.
Does everybody know what a continuous glucose monitor is on the committee?
No.
All right.
Okay. So a continuous glucose monitor is I call it a button. I have one on my arm, but it's a.
Do you? So this is up close and personal for you. That's great.
Look, I'm a type 2 diabetic. I do not take insulin. This CGM has changed my life. It is really, my A1C has gone from 10 down to 6.5.
Just clarification of that. So the goal is below 7.0. Diagnosis is at 6.5. And that gives us an average, if I remember correctly, I think 7.0 is 144. Anybody got that in the audience? I think that's about right.
Yeah. So this is it. I have a button on my arm. It comes straight to my phone every few minutes and lets me know where my glucose is. So when I eat a dinner, I can see what that dinner did to my blood sugar, and I can make adjustments throughout my life based on how I eat and when I eat and those kind of things.
So a little bit further background. So the reason you want it below 7.0 is it's about a 75% reduction in complication rate. So the closer you are to normal, the less complications you're going to have. And that means eye disease, losing toes, dialysis, and all the things that go along with diabetes. Anybody else with questions on continuous glucose monitoring? Why? So in gestational diabetes, that's been shown for decades, I guess, maybe 30 years, that if you have tight control of your diabetes, real good control of the blood sugars, better than 7.0, then you'll have less complications relating to the babies that are born. I mean, that's basically it. And continuous glucose monitor has been somewhat revolutionary. I hate using that word or overusing that word, but it has been used to help improve control and make it easier because, like Representative Seaball says, he's wearing just a button here and he can flash it as needed. There are a couple different types of glucose monitors. There are several, but there are two main ones. Any other questions besides Senator Orrock? No other questions. All right, Senator Orrock, it's you.
Thank you very much. Thanks to the author. Mine is on the history of this because we struck 2023. So was that the first time? Was that the first time that the glucose monitor came under coverage? And I don't know who would know that, Mr. Chair. You might be the one that knows that.
I don't remember the details on that. I bet someone in the audience does.
I'll have to phone a friend on that one.
All righty.
Hello, Brandy Sylvan with the Department of Community Health. So we did pass a bill last year that mandated coverage of these devices. So I think that's just being updated to say that this new requirement that gestational diabetes be an included disease state for coverage that's effective July 1st, 2025.
Any other questions?
So that was this expiration date was 2023.
It was originally introduced in 2023,
that was
but
my-
it passed in 2024.
Oh, okay.
And it was not updated in the.
I'm familiar with the device. I've got friends that rely on it. I think it's an essential new tool. So I'm happy to make a motion, Mr. Chairman. Appropriate time.
All right, we'll take a motion.
I moved to
Second.
pass LC 520828S.
Thank you so much. All those in favor say aye. Aye. All those opposed, like signs. Pass unanimously. Good, thank you. Anticipated that question. So we're all good. So I think we got everybody assigned. So we're, again, as the chairman of rules would appreciate, we're doing agency and department bills, governor's bills, and we're getting those out first. We got, I think, maybe 2 more on Wednesday. I really appreciate that. Thank you so much. And anything else, good and welfare? If not, meeting adjourned. Thank you.